Hello, welcome to Aging Well in America. I'm Anne Marie Gattari, your host. Today we have with us two very, very special people from Seasons, Hospice, and Palliative Care. And I'm going to just get right into it because this is a very important topic. Denise, welcome.
Thank you. Thanks for having us.
Dr. Wilborn, welcome and thank you for coming. Seasons Hospice is one of many hospice organizations in the United States, and there's a lot of choices for hospice when people are at that point in their lives and they feel that the service might be beneficial to their families and to their loved ones. Before we get into some of the things that differentiate Seasons from some other hospice organizations, because everyone has a little bit different way of doing some things, I'd like to just start by asking you just a little bit about what is hospice and how does a family know when it's the right time? So, Dr. Wilborn.
So, hospice is essentially a 6-month medical benefit that Medicare and most of the other insurance companies actually affords patients and families. Is meant for patients when they have been diagnosed with an advanced medical illness and have a prognosis of less than 6 months. It's a multidisciplinary approach to patients' care, so there's many disciplines that help care for the patient, including the physicians, the nurses, music therapists, social workers. So it's a wonderful support to patients and families at a very important time in their lives.
Excuse me. I know it is a wonderful benefit because as we were speaking before we started the show, I personally had the benefit of Seasons Hospice with both of my parents. And at that time, I remember my dad asking when a nurse, a Medicare nurse had told us, quite frankly, your father's at the end of his life, which was not a surprise to us. But when I asked him if he was in agreement and would, in fact, sign the papers, his question to me was, will this rush things? It's a quote I'll never forget, quite frankly. How do you answer a question like that from a family member? Will it rush things? Is it throwing in the towel? Are you giving up?
Yeah. I think that oftentimes at end of life, people feel like they're giving up when really they're not. We still offer hope in hospice. Our hope is that whatever that family's end of life experience is, that we are meeting their needs. Our hope is always changing through our life. As a child, we're hoping to get that special gift on our birthday or pizza for dinner, or as we age, our hope is always changing. And maybe that hope at end of life is that you are surrounded by your loved ones, that you pass away peacefully without any respiratory distress or pain and symptoms. That's what we do. So it's really not giving up. It's finding out from a patient and their family what it is they want at end of life and how we can meet those needs.
Well, that's such a beautiful way to look at it, quite frankly. But how do you know you're at end of life? I mean, that's really almost playing God in some ways. How do you know?
So we make best guesstimates. We don't know for sure. We certainly don't have crystal balls. So what we do is process extensive clinical information to arrive at a possibility that this patient or the person that you're dealing with has less than 6 months to live.
Okay.
You know, the common misinterpretation of hospice is that people are going to come onto hospice and die as soon as they sign on. So I can't tell you the number of times I've had that conversations with patients and family. We don't hasten. We certainly don't delay. We allow for natural passing, passing with dignity, which I think is something that we in the United States really need to revisit for sure.
Yes.
So we don't know. What we do is we collaborate with the primary care physicians who've been caring for patients for many, many years oftentimes. And when they've been diagnosed with a chronic medical illness that's progressive, when they're getting weaker, when their functional status is worsening, when there are no further medical treatments that can cure or fix the underlying problem, whether it's a heart problem or whether it's a cancer problem, that's about the time we know that the patient has a prognosis that's very limited. So the key thing to recognize and remember is that we don't have crystal balls for sure. We admit patients or bring patients onto service when we feel it's the appropriate time, as we're collaborating with their primary care physicians.
Okay.
And then when the patients are on service with us, they could be with us for 10 days. They could also be with us for 6.5 months. We really don't know.
Okay.
And that,
So-
I think, is completely up to the patient's process.
You said it's a 6-month benefit. Is there a period of time throughout those 6 months when you're reevaluating to see if the person continues to qualify for the benefit?
We do that. We do that at every stage.
Okay.
So one of my roles as medical director is to oversee our compliance as well as our quality and making sure that we're treating patients, the right patients,
Okay.
and providing them with the right benefits. So we evaluate them periodically.
How do you speak with families the families themselves, the adult children or the spouse might be reluctant to take that step? How do you speak with them when it's quite clear from a medical standpoint that hospice is the best way forward for this loved one?
I think it's important to find out from the family what it is they want for their loved one. Where do we fit into that place in their home that we can help support them ongoingly to make sure oftentimes people don't want to go back to the hospital, and we can help them stay at home because we're managing their symptoms and providing medications and support. And with the services that we have and a nurse and an aide coming into the home, we're giving that family time with their loved ones so that they're not running them back and forth to doctor's appointments or hospitals for needs. We're caring for them right in their own place. So it's important to find out what it is that they want out of these next weeks or months or year in hospice care, so that we can place ourselves in there and find out this is where we can benefit you. This is what you've said you want. This is how we can complement that for you.
So let's talk about the process. In my situation, it was my mother's primary care physician who asked us to consider hospice, and when we agreed to investigate it, he recommended Seasons, and it was on a Sunday, I believe. We received a phone call and set up a meeting for immediately the next day or the day following, and we had a nice team of there were a couple of nurses that came. I think there were 3 people who came out and explained the whole process. Is that a typical way it happens, or are there other ways that the process might start?
So I think the process may differ a little bit based on where the patient's located. So sometimes it's not ideal, but we institute hospice very emergently in a hospital setting, which, as you know, is not optimal for sure. So it varies whether the patient's at home, in a hospital, or in a facility. But I think the general approach is the same. So we contact the family. As soon as we get an order for hospice from the primary care physician or a physician who's intimately involved with the patient's care, we then contact the family to set up a time to meet with them. And during that meeting, we spend as much time as the family needs explaining to them what the different services are, what is the hospice benefit, what is the benefit to the patients and the families, and then there's legal documentation, of course, we can't get away from, so we certainly get that taken care of at that point in time. Some of the additional things that we address at that time is, kind of reapproach advanced medical directives, things like code status, which I think is important for us to address, and I wish people would address that.
Code status. So let's define that for us, please.
Sure. So a code status it's essentially getting patients and families to determine what the response should be in the event there's a catastrophic event that leads to a patient's heart stopping. So oftentimes when we think of code status or we hear the word code blue, the popular media representation of it is, patients who are 45 years old suddenly keel over and drop dead, and they are all brought back to life. But that's not the norm, because what we find is a lot of patients who get resuscitated are patients who have advanced medical illnesses, and the outcomes are so different from what it is if you're a 45-year-old with no medical illnesses and happen to have something catastrophic happen. So code status is really addressing what the patient would like done in the event that the heart stops beating or they're not able to breathe. So we like to address that ahead of time.
And the statuses are DNR, right?
So
Do not
Do not
resuscitate.
resuscitate. We'd like to change the way that's worded, because do not resuscitate almost gives out a negative connotation because we're not doing something. We think it's more appropriate to say allow natural death.
Okay.
Because that's more positive, because what we're doing is allowing something that's a natural progression, that's a natural circle of life to take place.
Okay.
So I think it's a better way to say it.
Okay.
The other is what we call a full code, or do everything, whereby we're proceeding through the resuscitation process. That
And
can
often
be very harsh.
that entails calling EMS, correct?
It entails calling EMS. It entails emergency responder arriving at the bedside to do chest compressions, which often lead to a lot of damage, including broken ribs, broken breastbone, and then leads to them being placed on a ventilator, which then leaves you with more difficult decisions to make.
In order to be eligible for hospice, must your code status be a DNR, do not resuscitate?
I'm glad you asked that question. The answer is no.
Okay.
It is completely up to the patient and the
Okay.
family, and we in Michigan recognize it's their right to have their wishes followed.
But I hear you kind of advocating for allow natural or
We do.
DNR.
And the reason we advocate for a DNR or allow natural death is because when patients present to us, they have very advanced illnesses, and the likelihood that we would be successful in a resuscitation attempt is very minimal. Oftentimes it's less than 1%.
Okay.
And even at that point in time, that 1% leaves you with more damage that you have to deal with.
As you
So it can
explained.
be extremely traumatic.
Right.
So we encourage, and we have multiple conversations about the benefit of a allowed natural passing.
Okay,
And
very
I think
good.
oftentimes it's just educating the family, not knowing what that means with the chest compressions
Sure.
and breaking bones and things of that. So if we're able to provide that education, and like Dr. Wilborn said, letting them know the benefit versus the burden of the DNR, helping them to support their decision, and so that they aren't left with guilt of making that decision.
And that when you say the guilt of making that decision, you're talking about now you must do something like disconnect from a
Right.
breathing machine, or is that what
That
you're?
is right.
Okay.
That is right.
Okay. Right now we're talking about, when we talk about the Medicare benefit, that's the elderly and those who are eligible for Medicare benefits. What about that 45-year-old who may have a brain tumor or cancer or some, and he obviously, or she is also medically eligible for hospice services, but they're not eligible for Medicare?
So,
How is that paid for?
So all private insurances typically will have a hospice benefit,
Okay.
as does the state-funded Medicaid program
Okay.
or HMOs. So there's always a benefit based on whichever insurance provider we work with. For that.
Okay. All right. I think that's another question.
We also will work with any insurance company, and we will also work with the patient and family. Perhaps they don't have insurance, those things. We do offer charity care. We go through a process, a meeting with the patient and family to
Okay.
find out what their financial situation is. So if they're not able to afford hospice care, then we will provide that charity care.
So you really try not to turn anybody
We
away.
won't turn anyone away.
Do not turn anybody away.
Okay. Okay. That's important to know, I think. Hospice, as we were talking about, is a very special it's a very special field. And people, Dr. Wilborn, you said earlier, it's not something that you seek, it seeks you. So tell us, if you wouldn't mind, please, your personal journey How did you become a medical director for Seasons Hospice?
So I trained as a resident at Oakwood and then spent many years at Oakwood as a hospitalist. So this is Oakwood
A
Hospital.
hospitalist is?
A hospitalist is a physician that primarily provides care for patients who are hospitalized.
Okay.
So what we do is we collaborate with the primary care physicians on the outside who send patients in to the hospital when they're sick. So as part of what I did as a hospitalist, I took care of very critically ill patients. Oftentimes they were elderly with multiple chronic medical illnesses that they were dealing with. So it was often that I had these conversations about advanced medical directives, what's important, what the prognosis is. So when Oakwood decided they were going to start a palliative care program, I was asked to be their palliative care medical director. So that's how I got involved with hospice and palliative medicine. After practicing for about a year and a half where I was doing both, I was a hospitalist and a part-time medical director for palliative care, I transitioned more towards just purely hospice and palliative care. The work that we do is very satisfying. I get often asked, isn't it extremely depressing to deal with patients at the end of life? And I have to say it's extremely satisfying because the patients and families come to us in times of distress. And when they're able to receive the care that we're able to provide at the end of life, it makes that experience so much more bearable and almost becomes, something that's accepted as a natural transition.
It's almost uplifting if it's done properly.
It is. So I think there's a lot of benefit that I get, personal satisfaction. I also want to relay a real quick personal story.
Sure,
which
please
is,
do.
When I was a medical student and had just finished my medical degree back home in India, I was called to my aunt's bedside to attend to her because she had massive seizures, and this is a young 42-year-old.
Okay.
Unfortunately, what happened was that she was diagnosed with a brain tumor and proceeded to have 5 years of absolute torture back home in India. And it's not that the system didn't allow it, it's just that hospice and palliative care certainly hasn't made its way there. In the U.S., we're very fortunate to have that service available to us. So my aunt, unfortunately, died at home with no support, no pain management, and it was quite a destroying experience for her mother, who was her primary caregiver.
Oh, my.
So I feel so much better that we're here and able to offer patients and families the care that we do. Makes a huge difference.
Yes, I can only imagine that it might. Denise, what about you?
I was fortunate enough that I just fell into hospice.
Okay.
I've been working in hospice for 24 years.
Oh, my.
And also find it very satisfying and rewarding at the end of the day, knowing that we were able to provide support to patients and families to get through that. Oftentimes people haven't experienced a death in their family, or every loss is different. So to be able to help them and support them through that is incredibly rewarding. I can't imagine having a career in anything else but hospice.
And your professional background, social work?
Nope, I have business background.
Okay. My goodness.
Yeah.
But you've probably become
Well, I
very
think
much
there's a good balance in
Sure.
that. And working in hospice, it puts a new perspective on life every day.
Yes.
You see family struggles, you see families come together because of hospice. So I think every situation is so different that there's a learning experience
Sure.
in working in hospice.
We have conferred Denise with an honorary nursing degree.
I was going to say,
that most of the folks that work on our team, even if they don't have medical degrees, are so committed to the mission.
Yeah.
I can't imagine working with a better set of people. I mean, they're just truly committed to the hospice and palliative care
that's
mission.
wonderful. You mentioned a few times palliative care, and I think that's another area I'm still not totally clear on what it is versus hospice. And is it actually ongoing care, or is it a consultation?
So palliative care is actually a new subspecialty of medicine, and essentially we have physicians now getting board certified through a fellowship program.
Oh, my.
It's a newer specialty, as you can imagine.
Is it in The specialty is it statewide or is it federal?
Nationwide.
It is nationwide. Okay.
It is nationwide, and we can train and become board certified as hospice and palliative care physicians. What palliative care is essentially, again, an interdisciplinary approach to patients' care when they've been diagnosed with a chronic illness at any stage in that illness. So where it differs from hospice is that patients who are in hospice have to meet that 6-month prognosis based on 2 physicians certifying them.
Okay.
Whereas with palliative care, it is access to palliative care professionals when you're diagnosed with a chronic illness. And it may be that you have years prior to passing that you can access palliative care. What palliative care does is essentially provide support for the patient as well as the family with multiple disciplines playing into that patient's care, such that we help them transition through that illness as they deal with it. So initially, when they're diagnosed, it could be just a little bit of support along with all the aggressive treatment they're getting. But as they progress along that course of the illness, the palliative support increases. We do a lot with symptom management. We help with establishing goals of care. And really, oftentimes, we're helping patients and families really process complex medical information that's thrown at them from many subspecialties.
So is it possible to receive palliative care while you're receiving the Medicare nursing and therapy benefits?
So
again,
yes,
also paid for by Medicare.
Yes, it
right?
is. So when patients are in a skilled setting in a nursing home, or they're getting home care at home, they can certainly access palliative care, because palliative care essentially is like a consult. Just like you can see your cardiologist, you can see the palliative medicine specialist.
I understand.
So typically palliative care specialists are collaborating with the primary care team. We don't take over the patient's care, but what we're doing is essentially providing additional support and consultative services.
Okay. And some of those consultative services, we haven't gotten into many of them, but I know from, again, personal experience, there's a social worker who will come to the home. And this is for palliative and hospice, or correct me if I'm wrong.
So
music therapy, chaplain.
Traditionally, the services that you're describing are what we offer with hospice.
With hospice, okay.
And what we tend to do with palliative care is we're tapping into what the patient already has access to. So oftentimes they're in a skilled setting. They already have a social worker who knows them extremely well. So we're working with the social worker there, or working with their primary team there, or the nursing staff there to provide care. So.
And if they're home, if they're not in a facility, if they're in their own private homes?
So in their private homes right now, our palliative care program, which is expanded into the community, we're mostly seeing patients in a skilled setting, in nursing homes, assisted livings.
Okay.
Our goal is to expand into the home setting because there's certainly a need.
Sure.
But we're looking to start small and grow as the service grows.
I see. We've got about 5 minutes left. I would like you to talk to us a little bit about Seasons specifically as a hospice organization and palliative care service in comparison to some of your competitors, if you will. One quick question. If your loved one is in a hospital and you want to bring him home or her home, is it most hospital systems have their own hospice service? Does the family have the choice to choose whichever hospice organization they want?
They absolutely have a choice. Some have had previous experiences with the hospice and they want to go back to that same hospice. They follow the recommendation of a physician, but a family has every opportunity to interview multiple hospices and find out what each of them have to offer, who they feel most comfortable with, because when you're faced with that end-of-life decision and enrolling in hospice, it's a sensitive time. So you want to feel confident in who's providing that care to you. So
why should we choose Seasons over another hospice?
Well, Seasons has multiple programs that we offer to patients and families. We are the largest employer of music therapists. They are not just entertainment. they do have 4-year degrees in therapy, and we really find that music therapy is beneficial at end of life. It can help with anxiety, loneliness, depression, those types of things. We one of the other things that I'm most proud of at Seasons are the legacy projects that we work with our families on.
Tell us about those.
They are, when meeting with the patient and family, finding out what maybe their last wish is, or something that they want to leave behind. Oftentimes that can be a video like what similar to what we're doing now. It may be leaving their voice on a book for grandchildren, so that the children have that for a long period of time.
Oh, how wonderful. So you help produce those?
Yes.
We creative
and we do that
artworks.
through Seasons works with the Hospice Foundation. So there are
wonderful.
people often want to give back to the hospice and the
Sure.
care that we've been able to provide to them as a thank you. And they make memorial contributions, and we will use those donations to supply the books or the CDs. We often, one of my favorites is getting a fingerprint of grandma or grandpa or mom and dad and having a necklace made
Yes.
out of the fingerprint.
Yes.
And that can all be funded through our Hospice Foundation.
Oh, that's wonderful. That's wonderful.
It's a real gift, something that they'll have forever. And I think those tangible things, when you lose someone, are very meaningful.
Absolutely.
There's many medical programs that we offer as well that certainly sets us apart, I think, as an organization. I have to say that I'm very proud that I'd say at least 85% of our providers, physicians, and NPs are actually hospice and palliative care board certified. So, and that is a very difficult thing to do because we're certainly a scarcity in the marketplace.
Is that right?
It is. So for every chronically ill patient, there's got to be about close to 1,500 chronically ill patients, and there's only one palliative care board certified physician. So,
And what does it take to become board certified?
so essentially you have to be a board certified internist or multiple other specialties like PM&R, ER physicians, and then you would essentially do a 1-year fellowship program.
I see.
There was a period of time where you could grandfather into it.
I see.
So as an organization, we employ a lot of our board certified providers. The other things that we do is our response times are extremely rapid. We're quick to respond. So oftentimes we're only limited by when the family is ready to meet with us.
Okay.
The other thing that sets us apart is what we call our open access program. And I'm very proud of our open access program because oftentimes we'll meet patients and families where they're at in the disease process.
I see.
So traditionally, people think of hospice as given up. What we tend to do is if you still have those 2 or 3 radiation treatments that you want to finish, we'll bring patients onto hospice and actually pay for those radiation treatments ourselves.
So that's what's considered open access.
It's an open access whereby
Okay.
we're reviewing clinical information, determining the need and the
Great.
appropriateness. So we have patients who say, well, I'm ready for hospice, but I'm not ready to give up
Right.
transfusion once every 3 months. So
Okay.
we give them blood transfusions, which
Oh,
I know
my.
is near and dear to Denise's heart.
Okay.
That said, so there's a lot of additional things that we are able
understand.
to support patients with.
Well, there's so much to be learned, and believe it or not, we have come to the end of our time here, but I would love to invite you back again so we can continue our conversation. Thank you so much,
you.
Dr. Wilborn, Denise.
Thank you for having
We have
us.
come to the end of another episode of Aging Well in America. Please send us your ideas and your questions here at the War Memorial for future shows. Thank you.